All right, everybody. Welcome. We got a quick hit for you today. This is Joe Walsh here with MurmurMD. I'm joined by Elliott Groves, our moderator for the Optimize LAC channel. Elliott, how's it going, bro?
Good. How you doing?
Good, man. So I just want to talk about this because this is something that's come up in my practice a lot, which is reimbursement and documentation for Watchmen. I apologize that this is a very dry topic, but I do think it's timely, and I do think more and more implanters are going to be running into issues with denials with pre-authorization, and I just wanted everybody to know exactly what needs to be in your documentation and to have some sort of strategy in place if you get denials for your LAC procedures. So just as a background, why are we documenting for these LAC procedures? Well, the first is you have to establish your indication. I mean, one of the most common reasons people get sued is the procedure wasn't indicated, right? So you want to document why the procedure was indicated for liability. You also want to document why it's indicated for reimbursement and for pre-auth. You also want to fulfill the requirements in your documentation as per the national coverage decision, so you don't have issues with your payers, and if you get audited, you're covered, that you are clean on your documentation and there's no issues that would be deviations. Thirdly, you do want to comply with registry requirements. These patients are entered into a registry, and so you do want to make sure on your pre, peri, and post-procedural documentation that you fulfilled all of the registry requirements. And lastly, you want to be able to track your procedure outcomes and your peri-procedure details. How many deployments did you do? How compressed was the device? Those are all obviously very important things with the procedure. So I'm just going to go through the current problem. This has really impacted us quite a bit. And so while Medicare does not require pre-authorization for LAC procedures, Medicare Advantage plans and commercial insurance plans do require pre-authorization. And this can delay the procedure by up to 2 weeks, even longer if there is a denial that requires a peer-to-peer or some sort of fight against the denial. Medicare Advantage and commercial insurance plans have been denying a large amount of LAC procedures. In my practice over the last 6 months, probably 12 denials I've gotten. And this pre-authorization process, in addition to denials that require peer-to-peer discussions, can be time consuming, and they can delay treatment for patients that really need it. And so what I found is, since I've buffed up my documentation on my consult notes for these LAC procedures, that we've been able to bypass some of these delays and get approvals in a more timely manner for our patients. And we do know these Medicare Advantage plans are growing rapidly. Essentially, these private insurers just kind of buy out their Medicare plan, and then they require pre-authorization on everything, and they're much more scrutinous in terms of whether the procedure is indicated or not. So this is just a quick overview of things you have to include in your initial consult note on my review of the data. And again, what my recommendation would be is, if you don't have these things already in a smart phrase, just create a smart phrase from these. We're going to make these available on the app, so you can just copy and paste them into a Word document or an email and put it into your Epic. But these are smart phrases that I derive directly from the national coverage decision and the LAO registry. And so when I see a Watchman consult, it takes me about 3 minutes to do my note, and I just go through and I populate these smart phrases, and the documentation's clean, everything's ready to go, and we are in compliance with everything that we need to be. So the first thing is just the HPI. And so this is straight from the national coverage decision. He or she is at high risk for stroke. You document their CHA2DS2-VASc score, their Has blood score. You document that they are a candidate for short-term anticoagulation, and they are not a candidate for long-term anticoagulation due to XYZ. And you can just fill in the blanks here. Importantly, you also have to document that the patient has non-valvular AFib. And a lot of people don't know this, but you have to have a documented episode of AFib within the last 5 years. So if you see a patient who had a remote episode of AFib 10 years ago, and there's nothing in the chart, there's no EKG, there's no remote monitoring device, there's nothing. Unfortunately, if you get audited, that's going to be a ding on your program. So you do have to have your coordinators, unfortunately, scour the chart to make sure there is a documentation of atrial fibrillation, and you put it in your note. In terms of your plan, you have to have NYHA class for the registry data. And then you have to have the shared decision-making tool that a independent non-interventional physician fills out. And so I just put that in my note that that's been completed. Our coordinators do that on the back end. And so that's important as well. Elliott, how do you guys do that with your Watchman program? Because I do think this is kind of a pain point for a lot of programs.
Yeah, so we changed it up recently, actually. So we made our own template note for the non-implanting physician, and what my coordinator does is she writes the note for them and then has them sign it in Epic. So we use Epic, and the vast majority of my referring doctors use Epic. And for the non-Epic users, we actually just contact them and ask that they essentially document that they refer the patient, which most of them already have. But we have a very detailed note um, that we send to most of the people in my own group. And then in terms of some of the other stuff you mentioned, I think to expound on your point about about the AFib documentation, I've actually had a few people get sent to me who never actually had AFib.
Yeah,
You know,
yeah.
it's
And you're
just
like,
kind of
you can come off
yeah,
anticoagulation.
yeah.
Congratulations.
It's just chart lore. 12 years ago they were admitted for sepsis and they didn't act, and they had EKG with a tremulous baseline, but it was sinus or sinus attack or something. So it's
Yeah.
important to document.
No, that's a great
Um,
point. I love the Epic thing. So what do
yeah.
you just do a letter? Like,
Yep.
oh, that's fantastic. And it's just in
Yeah.
the, that's so much more efficient, man. We still do the
Yeah.
old like paper one that they sign and then we put it in the, like the media section and stuff like that. I love
Yeah,
that. That's a great,
they just co-sign it. It's very easy for them, very easy for us, because the coordinator just made this very detailed template. The same thing as you were mentioning, just bang, 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 do a couple of things. And as far as we know, I mean, we haven't gotten audited, but we're hoping that if we
yeah.
do, that it's sufficient. And one other thing we do that I think is useful is because we generally are booking out more than a month, and so mine or my colleagues' consult notes are older, more than 30 days. She needs an HP. Our nurse practitioner, we have one nurse practitioner who just does LAAC, and she has a template note like this. So it's just within like a week of the procedure, all of these things, just Chad's Vass, has bled, short-term anticoagulation, okay, long-term anticoagulation, not okay, just a very templated note that she puts into just to reinforce it over and over again.
No, I love that. That's great. And we'll share some of the shared decision-making tools. Boston has some good ones. And so for those of you that don't have one that you're using or if you need a copy of some template, we can share that with you. Modified Rankin score is required by the registry. You also do want to document if the patient had a stroke and is aphasic or has an issue. Make sure you document that beforehand, just to cover from a liabilities perspective. And then again, just kind of the template phrase for risks and benefits and alternatives. And then the last thing that I've been doing, which is really nice, our structural heart PAs really love this, is when I talk to the patient in clinic and we're discussing the plan for the procedure, we prospectively determine what our anticoagulation strategy will be. And we've kind of gone back to DOAC pretty much as a default for everybody because of the data showing that aspirin Plavix have a higher bleeding risk. So is that something you guys do too, Elliot? Do you determine their post-procedural anticoagulation strategy at the consult appointment?
Yeah, actually, we put it in that NP note I was talking about. So that has the post procedure plan. I mean,
That's great.
what she does is she talks about it with whoever we do. We have an EP and I who do the procedure, and we do them all together. So she just grabs whichever one of us is that patient's referring doctor basically, and we tell her. But yeah, so we doc because I think I 100% agree with you. It's super useful because the day of the procedure, like we're doing like six in 4 hours or something like that to two rooms, and like figuring out what we're supposed to be doing with that person's anticoagulation when you're like running back and forth between two rooms, not suboptimal.
Yeah, no, absolutely. Yeah, so this is kind of the basic gist of HPI and plan for your consult notes you'll need to include. So in my experience with these peer-to-peers, if you get a denial, it's nice to have kind of a playbook for your coordinators. So make sure when they get called about the denial, that they ask, what is the reason for the appeal? So you're ready to respond to it when you have your peer-to-peer discussion. Was it a documentation issue? Was it a patient criteria? They didn't meet the CHADS VASC or something like that. Or is your coverage just not covering this and it's a commercial payer that doesn't cover this? And review all these specifics of the denial before the call so you're not kind of figuring this out as you go. And then you can request the peer-to-peer with a like specialty physician. So, a cardiologist, interventional cardiologist, electrophysiologist, somebody that has some knowledge of atrial fibrillation and left atrial appendage closure. So that's something that you have the right to do, is request a peer-to-peer with a like specialty physician. And then in my experience, most of the time the reviewer basically just looks at your note and has a copy of the NCD in front of them, or whatever the Medicare Advantage plan's interpretation of the NCD is. Commercial insurance does not have to follow the NCD, but they usually do. And I think it's important they don't have to have like life limiting bleeding or a history of massive GI bleeds, just a reason to not have long-term anticoagulation. So for more resources, there's a lot of resources on the Optimize LAC channel. If you scroll through the tabs on top, under program resources, there's an 11-page document that's extremely helpful, both for you and your coordinators to access, which goes over all the reimbursement issues that can happen. Boston Scientific walks you through the process very nicely here. We're going to link this to the post here if you want to access that. You can print it out, give it to your coordinators. And then if you have any more detailed questions, you can email Boston Scientific at watchman.reimbursement@bostonscientific or bcsi.com. And so a lot of resources here. I do think this is going to become a bigger problem as these Medicare Advantage plans become larger. And so I do think we have to have some tools in our armamentarium to deal with this so that we can get patients treated in a timely manner. So Elliott, any closing thoughts or pearls of wisdom for our community?
Yeah, just do this up front. You don't want to deal with this on the back end. Having to redo stuff or we had a rash of denials for an NP making up just a simple documentation mistake. And so that was kind of why we tightened our ship up and made it a more streamlined process because it can happen to anybody.
Yeah. Yeah. And just prospectively doing it and, sharing your notes across your entire team. So there's consistency, right? So everyone's using the same dot phrases. There's not, a black sheep using, dot phrases that don't fulfill the NCD requirement. But I think that's a great point, is just fix this prospectively, early in your program so you don't have to deal with these denials, because it does impact patient care and it will impact your program in the long term. So
Seriously.
cool. Quick hit. Well, Elliott, thank you. I appreciate it.